There we go. Too many people trying to do the same thing. So this is the yeah, yeah. This is our normal CME required conflict of interest statement. Our speaker has no additional conflicts, and it's just the usual two from Tom Powell and myself, who are members of the committee that organized this. So I want to use this also to introduce our speaker. Kenley Money is the director of the Information System Architecture at the Arkansas Center for Health Improvement, or ACHI. You may or may not know about ACHI, but I think by the end of the talk you will know a lot about it and will be as excited about this resource as I am, because Arkansas has some very unique data resources to facilitate population-based research. And we're going to hear about those resources. Ms. Money's expertise is really in health and lifestyle data integration. And what I was impressed with is really the depth of knowledge she has about data acquisition, data curation, how to take a lot of complex data, and in one case, different types of claims data, insurance claims data, but integrated into a useful information repository. And so again, that's one of the things we're going to hear about, because our current work is really focused on the implementation of the Arkansas All-Payer Claims Database, which is one of those, many states have, well, several states have such resources, but ours literally has all public and private payers contributing to it, so we can actually track the health procedures performed on residents of Arkansas, regardless of where they received their health care. So it allows us to go beyond our own data warehouses. And so I think this is a really exciting resource, and I'm interested in learning more about it. And I'm happy to say that Kenley is the newest adjunct faculty member of the Department of Biomedical Informatics to help us be better integrated and facilitate access to these resources. So now what I'm going to do is launch her slides and turn the podium over. There you go. And thank you.
Thank you very much. There's a clock up here. Welcome, everybody. I'm going to reintroduce myself. My name is Kenley Money. My title is Director of Information Systems Architecture. That's a lot of syllables to mean that the teams that I manage and build the data assets at the Arkansas Center for Health Improvement, or ACHI. When I first started at ACHI, I called it ACHI. That is not correct. But if you read it that way, that's what it seems like it sounds. I just wanted to share that with you if you had to say it in public some other. But you can see here, we are going to talk about today the Arkansas Health Policy and Healthcare Transparency Data Assets for ACHI. A quick agenda of what we're going to talk about. We're going to introduce you to ACHI. Some of you may know us. If not, enjoy the story. If so, a little repetition never hurts. And then we're going to talk about our data assets. And I should be clear that my team, my role in the management of these data assets is just that. My teams take the data, clean the data, load the data, make the data usable. At ACHI, we have a research team and a policy team that consume the data, and also external researchers, or data requesters, which we will get to. I have some information in here about the use of the data, but I'm the data geek, and our policy team, led by our director, Dr. Joe Thompson, they're the visionaries of how to use the data. If you want to talk about use, I can get there, but I just want to set your expectation. Let's first talk about ACHI. ACHI, or the Arkansas Center for Health Improvement, we are a nonpartisan independent health policy center dedicated to improving the health of Arkansans. We were established in 1998, and we have proven experience in the management and integration of health data to support research and health policy. Our mission, vision, and statements and core values really describe what we do. We are a catalyst to improve the health of Arkansans. And our primary role is as a health policy shop to inform agencies, the legislature, the executive office on the health of Arkansans, asking and answering many, many questions about health disparities, about providing information that can set law. We'll talk, there's a list, one moment. Some major accomplishments in the past few years. There are 2 slides here, but I want to, let's see. In 2000, our ACI was instrumental in getting the Tobacco Settlement Proceeds Act. In 2003, Act 1035 was passed that started the Health Data Initiative. That's our flagship data asset. I have slides on that. Let's move down to one of my favorite 2. In 2009, it was data and work from ACI that compelled the legislature to pass the seatbelt law. Like it or not, we're required by law to pass the seatbelt, or to wear your seatbelt when you drive. What ACI did was integrate hospital discharge data, state police crash data, and death data, and crunch the numbers and build the statistics that said, yes, indeed, if you are in an accident and you're not wearing your seatbelt, your chances of injury or death are far greater. In addition to that, the graduated driver's license regulation has had very compelling results in reducing the number of teen deaths because of the restrictions of this law. You can only drive at a certain time of day, etc., at a certain age until you're, 21, let's move to the next slide. We worked on fluoridation. We worked on the multi-payer Arkansas Healthcare Payment Improvement Initiative. It used to be just called Payment Improvement, where we helped bring together the carriers and Medicaid to do episodes of care. Let's see, and down at the end, which is mostly what we're going to talk about today, is the Healthcare Transparency Initiative of 2015. There are many more. Go to our website, www.aci.net. There are lots and lots of accomplishments and issue briefs and white papers, etc., for you to read. Our flagship data asset, the Health Data Initiative, or HDI. The HDI as an initiative really is an umbrella that describes the integration of all sorts of data sets for health policy. And you saw in the previous, well, I'll get ahead of myself. It was established in 2003, Act 1035. And if you look at the 3rd bullet and the sub-bullets, it gives ACI access to personally identifiable information collected by state agencies with state agency permission, and enable the development and maintenance of a robust and scalable data analytic warehouse. So what we did, when this was passed, we worked with the state agencies to acquire, with their permission and approval, a very rich collection of data. I have a list in a slide or 2, and with the PII on it. So we got this data with name, address, social, date of birth, gender, race, etc., and we were able to integrate it and cross it, and with a match engine, which I have a slide on, that will track individuals across these sources and across time. The catch, though, this is a very rich data set, is that it is for health policy research only. So access to this data is very limited. There is a little window of access, but we have to be, there are many, many conditions that we have to follow to get it. Excuse me. The HDI, part of my discussion today is to talk about the governance of these data assets. The HDI strategic direction is advised by an advisory committee. We also have IRB approval, and as we just talked about, external researchers there's limited access, but it is accessible. Some key projects that we have done, you may or may not have heard of. The top one you may have is our work with statewide body mass index data collection and reporting. Every year we collect, the Department of Education provides to us their student roster data after school begins. We load that to a web tool, and the school nurses take BMI or height and weight readings from all the students, even grades K through 10, every year. It began all grades, but then they cut it back because of the level of work that it was. Anyway, but K through 10, and this data is sent, we retrieve it, and we send it through our processes to build a final state report that calculates and tracks BMI across Arkansas children. And we have longitudinal data from 2003 forward for childhood obesity. It's probably the richest data asset in the state. And it's the one that people are most interested in. And it is usable, but with caveats. Other things we have done, the state employee health risk assessment and wellness strategy. The state employees in public schools are insured by the Employee Benefits Division. We get that data. They have a health risk assessment where they collect adult BMI information and other behavioral information like smoking and exercise, and we can do similar reporting on that. We just talked about the graduated driver's license. I'm going to go to the last bullet first, the emergency department use analysis. What are the top reasons the people go to the emergency room in hospitals across the state? But the next to the last one, interventions for obesity prevention targeting young children in at-risk environments. That is a study conducted by the University of Arkansas Department of Agriculture. They got a grant and permission to use our BMI data, and they have executed a very long-term project. One of the snippets is to track the fast food restaurants on routes to school and track the relative BMI of those students. And they have found that those kids have higher BMI. It is on our website. It's interesting to read. As I said, I'm the data geek. So this is our data environment for the Health Data Initiative. The red disc cylinders at the top represent our data sources. We receive them sporadically. The HDI is updated once a year. The data is pretty old generally. If you've worked with vital statistics data, birth certificates, death certificates, you know that you almost always have older data. Right now we have through 2014, and we're going to get our 2015 data this month. We receive it, we clean it, we run it through a thing called the GME, which is our identity resolution process, and it all goes into a knowledge repository, which is de-identified and into an analytic warehouse, which our research team accesses. And if ultimately you use this data and you go through everything to get use of this data, your data would be pulled from this analytic data warehouse. And we combine this with other data sets. I've listed some here, but there are many that aren't listed, and you can bring your own data in if necessary, if that's how the project works and you get approval, and merge it with the data that you've selected. The GME, the match engine, is my favorite part of the whole process. A little history. I spent 16 years at Axiom down the road, and Axiom is a data integrator for advertising and marketing. And all the junk mail you get comes from Axiom. But at its core, they have a tool it's called Abilitech, which is neither here nor there, but it is the tool that has all the business rules that match the name and address information and identify across many different variations of an individual's information the one person. And it assigns what we call a PID, a personal identifier, to that person. So if I get, I got ahead of myself. So what we did was we licensed a behind the firewall version of this tool, and we call it the GME, or generic match engine. So it resides in our secure data environment. I'm going to go back a slide. Oops. The box on the left that says ACI Data Hub, that is our secure data environment. It's called our closed network, and all the PII stays there. It is not accessible to the outside world. It doesn't plug into the wall. You have to have special permission to even get into the room where that is. So our match engine, which uses all the PII, is in that room, in the secure room. So let's fast forward. So that's why I say a behind the firewall version of it. So we use this tool to merge all the PII. So with that, I could, in effect, and I have, I could track a person from birth to when they're in school, to if they have a car accident, to if they go to the hospital, to if I had enough data, to when they die, if I have a death certificate for them. This page illustrates how the disparate data coming in can be merged and the final one selected on the out. And there are processes for every update if new data comes in. So it is what makes the HDI, it's the differentiator in how we manage identities on the HDI. Our HDI data sources include the Arkansas Department of Health vital statistics data, including birth, death, hospital discharge, emergency department events. We also get the cancer registry, which is down a little. We have the the employee benefits division, health insurance claims, mentioned that. The Arkansas State Police crash data, my favorite data set. The BMI student data. Delta dental claims data, Arkansas Medicare and Arkansas Medicaid data. And you can see the date ranges. These are current right now, but we update all the time. So, and as I said, for example, the vital statistics data, we will update. We got the death data early. If you want to access this data, well, first of all, there's some more description on our website, or you're welcome to reach out to me. But you would have to submit a data request, and we would review it internally at ACI to look at use and proposed use and the type of data, et cetera. Then we have to go to all the data owners to ask individual permission to use the data. Well, you can, at the top, you can see we'd have to go with each one, and quite possibly there would be data use agreements executed individually for them. And then we pull the data, assuming it gets approved, execute the analysis. Assuming we do that, sometimes the requester will do it themselves. And then the data owner would have to review the results, and then we would approve the output. It's not an unfamiliar process, but this HDI data is locked down for health policy use, so there would be some negotiating to do if this is the data resource that you wanted. All right, we've had the HDI since 2003. Now in the 2012, we started down the course of the all-payer claims database. Why? To support healthcare transparency. So we've all experienced the lack of healthcare transparency. We've seen it on the news, we've felt it in our personal lives with ourselves or our family. And I just put this graphic up just as a teaser. You know, nearly 2/3 say that it's difficult to find out what medical care will cost, and that's absolutely true. Quick graphic, this one is from 2015. So with that question in mind, we started down this journey. And so we asked why healthcare cost transparency? There are thousands, this is very dense, I realize, so we'll just pop through this and then you can read the presentation later. Newly insured patients gaining coverage through the state and local marketplaces mandated by the ACA are expected to take on high deductibles. So if you, just for example, if you are getting insurance off the marketplace and you have to buy a plan that has a very high deductible, that means you're going to want to know what your medical procedures cost so that you will know which plan to take or how to manage your money. So the idea of healthcare transparency is to make these available to you. Let's go to the next slide. The price transparency also benefits employers who need to identify high-value providers for employer-sponsored health plans. We have gotten calls from employers locally about, how can I get this data? How do I know which providers are gouging me? Do I know? Is it even true? Maybe the providers I work with don't, and it just seems like it. So, excuse me. So we have the best tool to fight or to achieve transparency is data. And an all-payer claims database is a large-scale database that systematically collects healthcare data from a variety of sources. It typically includes medical, pharmacy, and dental claims with eligibility or member and provider files. And we link all the data together. Some APCDs link data with the hospital discharge, immunization, and other clinical information. So that's the definition. What are the benefits? We've talked about that. Help consumers make informed decisions, supports research, allows for peer-to-peer comparison, provides more robust data for transformation efforts. 15 other states have an APCD of some sort. There are several more who are interested in getting one. The variations in them include the requirements for the submission of data, the variables collected, functionality, governance, and sustainability models. Some are paid for entirely with state money. Some are, for all intents and purposes, private. Some can't give data to researchers. Some can. Some have health department data. Some don't. Lots of variation. This is the map. There is a website called apcdcouncil.org. It has information on all the APCDs and those states that are interested. And they have a site on their website that has a lot of great information that's broken down, and you can see a button for researchers if you're interested in what other states have done with their APCDs. Ultimately, will be up there too. I should also say, in the differentiator between APCDs is that some have Medicaid and Medicare data, but most do not because of the difficulty in accessing that data. So our early vision, back in around 2011 or 2012, ACI thought, what is this APCD thing, and do we need it? I think we do, so let's start talking about it. So we developed a voluntary APCD prototype, and we based it on our HDI warehouse. And we called it the APCD Plus for health system change. The plus meant that we would have the health department data because the intent was that this would have all the PII on it. And the focus was, at that time, health policy research with expanded emphasis on health system change for cost reduction. Not really consumer facing. We knew we'd have a fight to release data in that way at that time. In 2013, the Arkansas Insurance Department Rate Review Division, HERD, if I mention it again, I'll say HERD, applied for and received 2 grants from SCIO. They called it Cycle 3 and Cycle 4. And the idea was to build an all-payer claims database that would ultimately help with rate review. But the primary purpose was to support healthcare transparency. Well, that's the name of it there. The grants, there were 2 grants. The large one was Cycle 3. It was $1.7 million over 18 months. It was competitively bid, and we won the RFP in 2014, and the contract began in June of 2014. The next one was Cycle 4, which it overlapped just a little. You can see by the dates there, it was another $1 million that enabled us to put the finishing touches on what we could for the APCD. The difference is that in this very first contract, the Cycle 3 contract, we continued with a voluntary data submission model and with PII. We had already engaged Medicaid. We had all the Medicaid data. We had Medicare data. And we had EBD data, Employee Benefits Division data. But when we went to ask the carriers for data, they said no. We will not share our data. We do not have to. We will not share our data, especially data with PII on it. That was because it was voluntary and no mandate existed. Their concerns the carrier concerns included data security, HIPAA compliance. Probably the most significant one is published reimbursement rates. And they were very, very concerned that reimbursement rates would be exposed and one hospital would learn what another hospital was being paid because it isn't the same. Explicit contractual restrictions on the release of provider information. Many of the carriers, Blue Cross, Call Choice, Humana, United, they have contracts with their providers that protect the provider data from being released. And then the lack of ownership of self-funded employer data, that is a kind of a broad statement, but let's take Walmart, for example. They are a self-funded private company. They use Blue Cross as a TPA. So who really owns the data? Is it Blue Cross or is it Walmart? Well, that kind of got sidestepped because all of the self-funded employers didn't have to participate in the APCD ultimately. I'll get to that. Provider concerns were published quality measures and published reimbursement rates. They too were concerned about about the exposure of what they might be paid by a carrier, but mostly they were concerned about the perception of poor quality of care. If information is published without sufficient explanation to the consumer, they might not understand what it means and may think the provider provides poor quality of care. So we struggled with this for a year. We got the contract in June of 2014 and struggled until the following spring, and that was a legislative session in 2015, and we, with the insurance department, submitted proposed legislation, which was ultimately passed, Act 1233 of 2015, and that mandated private carriers to give data to the APCD. It does several things. And this is important if ultimately you're going to request data from this data asset to understand the pieces. This act creates the Healthcare Transparency Initiative, which is the governing body. It establishes a mandate for certain entities to submit claims information. All private carriers that have 2,000 or more covered lives, and there's some other carriers other data providers, which will be listed in a moment. Provides authority for the insurance department, AID, to develop rules for data collection. Ensures data protection. It's not FOIable, and we can't re-identify data that we receive or publish. And it establishes funds for operations to make data available contingent on other available funds. What it did is provide a budget line item, but it doesn't have any money in it. Not yet. The vision and mission of the mandated APCD to empower Arkansans to drive, deliver, and seek out value in the health system, to serve as a trusted and timely source of dynamic information to guide meaningful action to improve health, enhance quality, and lower cost. The objectives: support efforts to improve healthcare quality, support the development of cost containment strategies, provide information about healthcare spending and utilization, inform consumers, health insurance carriers, policymakers, and providers on healthcare decision-making, to serve as a public good and support research. Serve as a public good is very broad, of course, but the idea is to give information to consumers ultimately so that they can make better decisions. What will be submitted? The insurance carriers will submit enrollment data or member data. The idea is it's all the member data, even members who don't have claims. There will be, well, and here's the difference between the APCD and the HDI. The APCD, after it got through all of the debates in the legislature, had to sacrifice the personal identifiers to pass. Some APCDs in the country do not have personal identifiers. It is problematic, but their intent, and the intent here, was that something is better than nothing. So we can begin with the data, show the value, and then seek out personal identifiers. But we do have the unique identifiers within a carrier. So for example, if I have in Blue Cross Blue Shield of Arkansas data, I have their member ID, I have their gender and their date of birth and the state in which they live and the county in which they live and their zip code. So I can match that person within Blue Cross Blue Shield and within Qual Choice and within other carriers. I can't match them accurately across, but we did request a unique identifier that was a hashed version of the last name and date of birth. So it's kind of a sneaky way to more solidly identify an individual. We don't know their name, we don't know where they live, but what we have is we have a big hash key that represents their last name and date of birth. For example, my last name is Money. I'm not going to tell you my date of birth because I'm too old, but there's XYZ 1, 2, 3, 4, 5, 6, 7. That's my hash ID. And if I had a Blue Cross claim and a Qual Choice claim, which I do, then that hash key, the ID, would be the same on both records. We will use that with member IDs and other information like creative review of when Procedures were administered or diagnoses were placed with dates. So for example, John Smith and his birthday, who lives in Texarkana, and John Smith and the same birthday who lives in Fort Smith, different counties, different regions, different hospitals, and same date of birth. Their hash key would look the same, but using the activity data, you can begin to at least tell that they are not the same person. If he has the same thing happening on the same day in two different, or anything happening on the same day in two different regions. So there are ways to get around it. Where we get medical claims, pharmacy claims, dental claims, and provider data in the APCD. Who will submit data? I alluded to this a moment ago. All issuers of health and dental plans in Arkansas with 2,000 covered lives or more. There are many. Right now we have 63 different carriers submitting data, and there are more in the state, a lot more. But they have one-offs, 100 lives here, 25 lives there. The retirees that move into Arkansas that keep their plans from wherever they live. We get Medicaid and Medicare, state and public school employees benefits. We know this, EBD. We have the Arkansas workers' compensation claims data. We also get the pharmacy data from pharmacy benefit managers. Not all carriers manage their own pharmacy data, and some have different TPAs. Entities providing medical services under contract with the state prison system. We haven't gotten the prison data yet, but when we are ready, we can ask for it. Prison data, prison medical claims look much different than a regular health claim. And then self-funded plans as allowed by federal law. Right now, the law says that a self-funded plan does not have to submit data to the APCD that is being addressed. So the Walmarts of the world, Tyson's, they're self-funded. They don't have to submit their data to us. This is the governance structure. In the legislation, the insurance department is the authority. They're the ones that ultimately approve data requests. And we are the administrator. ACI is the administrator, so we manage the database. All use of the APCD data has to be approved by the initiative board, and there is a data oversight committee and a scientific advisory committee that they review the requests to ultimately give permission or recommendations to the insurance commissioner for approval. There are all sorts of people involved here. So we talked about the insurance department, us, and the board. And then the board is made up of representatives from the following departments. And I won't read that, so you can read that. I think I said that there was the legislation, and the insurance department has a rule that outlines the data submission. So if you read the law, it doesn't talk about what fields to use and when to submit your data. What it does is it refers to the rule by the insurance department that has all of that detail. It defines how the carriers interact with us, what data that they are to provide, et cetera. After the rule was put in place, we abandoned the voluntary data submission, or the voluntary APCD, and we focused entirely on the de-identified data that they are going to give us, limited data that they're going to give us. And we redesigned our approach to make it far more automated. Once we have all the processes in place, we will be able to receive and update the database quarterly with health insurance claims that are 3 months, that have a 3-month lag. Right now, we are at the final stages of the first data build. All carriers were supposed to give data from 2013 to 2015. We're at the January 2017, and we have almost all the data in place. Our first quarterly submission is due on March 31st. It will be very interesting indeed. This is how it goes. Data is submitted, it hits a landing zone, staged, and it is put into a database or a data warehouse for analysis, for access. This is by the external users through us after approval. Will this work? Can we go to the website? Do you know? We'll give it, oh, here we go. We should have tested this before. All right, the Arkansas APCD website. Right now, it is mostly a data management tool for carriers to use, but I wanted to point to this. There's another reference in this deck, the data submission guide. Let's go to this one right here. This is the data dictionary, and it's out there for all to use and enjoy. Let's see, where's my view? It's very large. Well, anyway, so this document right here, you're not going to do it, are you? All right. Forgive the bunch of stuff. It's catching up, I promise. No, we didn't. Okay. So it has, I've got a hand. It has a section for each type of data. This particular section, to save you the bother of me going through all the pages, is for dental claims. And dental claims always begin with a DC, medical claims MC, pharmacy PC, and yeah, there's a header right there, dental claims data. And so the carriers take this document and they build their data feeds for the all payer claims database in this layout. And they have to meet all of the value requirements, the variable and value requirements that are in this document. That is mandated, and that's the business model of all the APCDs in the country. So you'll see in this column over here, there are instructions if it's a required field or an optional field. There are some fields we didn't need to turn on the first build, we're turning them on the second. Some fields are wishful thinking someday, and if it is a required field, then this percentage is how much coverage they're supposed to give us. Now, it is quite often that the carrier will say, I don't have data in every single field. And depending on the field, we have to say, well, either you have a problem, you need to fix it and give us the data, or sometimes you just can't do it. For example, we received some health claims from a very small carrier 2 weeks ago. Their principal diagnosis code is supposed to be 100% populated. And it wasn't. It failed on 5 records. So upon investigation, we found that those 5 records had procedure codes in them, ICD-9 procedure codes instead of diagnosis codes. So they couldn't help it. The carrier couldn't help it. The provider is the one who sent the data, and it was probably bad data anyway. So what we did is we gave them a buy, and we let them submit the data and just tweak this threshold. Data quality problems will exist everywhere. Our goal here is to minimize the impact as much as possible. And incidentally, after data receipt and it goes into the data warehouse, those 5 procedure codes would be made null in the primary diagnosis code field, so you wouldn't have to worry about it when the time comes. All right, so this is our data submission guide. Go back. Poke around on this side all you want. You're welcome to look at anything. You'll see this one says 2015 and this one says 2017. We're adding some new fields for the data we'll start getting in March. Take a look and see. All right, let me look at the time, 12:40. Oh, oops. Hang on. There we go. I did that, yay. All right, 63 participating submitting entities. I said that earlier, carriers and payers. Historical data load range, 2013 to 2015. Ongoing submissions begin in March 2017. We mentioned that too. If you're interested in how that goes, it's all inside the data submission guide. All that's documented. And we just looked at the data submission guide. When you get this, you can click on the link. Our data intake status. First, let me say that we're almost there with our historical data submission. 90%, we have over 90% of the covered lives in Arkansas today. These are the carriers that we are receiving data from, and you'll think there are not 63 carriers here. Well, some carriers have multiple companies underneath them. For example, United Healthcare has about 10. So we're getting data from those 10 companies, although United is represented as a single thing here somewhere. There it is right there. The red line represents the number of companies underneath the carrier. For example, Anthem has 17 little companies that serve Arkansas, so we're supposed to get data from all 17. The good news is they're going to funnel it through a single channel. Yay. But they don't have very many covered lives. For all those 17, we are only going to get about 8,000 covered lives from Anthem. Arkansas Medicaid's, oh, yes, sir.
I'm curious about the 90% up there, the covered lives. Does that mean you've got 90% of the folks that have over 2,000 that are supposed to respond to you, or 90% of all Arkansans that are covered?
It's the former, of all the folks that are supposed to respond.
And what percent is that of all Arkansas lives covered?
It's, I have to
figure out that
where it is.
2,000 and those few that are exempt, like Walmart and Tyson, would be quite a few.
That would be. So let me do some math real fast. So Medicaid and Medicare are around 800,000 covered lives each. Yeah, there's a tiny bit of overlap for the dually eligible, and it's 3 years of data, I should say. So there's going to be some slough, either those that come on and off. And our EBD universe is 150,000 people, and Blue Cross Blue Shield is about 80,000 people. So I'm going to say 2/3, perhaps, especially now that we have with the ACA, you're supposed to have health insurance. There are not that many that don't. So that is a statistic I shall add to this slide. All right. The data request process for the APCD. The APCD is designed to be accessible. The idea was that data will be available for purchase and use by external entities, unlike the HDI, which is very locked down for a single use to support Arkansas health policy. The overall use of APCD data should focus on transparency and healthcare system improvement, and by and large, that's what's going to happen. The data request process is illustrated here. A request will be submitted. Right now, it's manual. There will be a form on the website that you would submit. Ultimately, it'll be a web form instead of a PDF. It's submitted. The ACI teams review it. It goes to the transparency board. There's probably an iterative process in there where we would work with the submitter to ask questions, to understand requirements. With Healthcare Transparency Board approval, it goes to the Insurance Department Commissioner, and then the DUAs and contracts are executed. We pull the data and we send it out to you. Now, right now, this is not available because we don't have all the historical data yet, and there is a lot of work going on with other sustainability projects. But we expect that APCD is going to be available. It will be available this year, most definitely, for data requests. If you are interested in using it, don't hesitate to reach out, and because we'll put you in the queue. We'll put you, as soon as this is ready, we're going to contact everybody who's contacted us to date. There is I didn't put it on here, but there's an email, arapcd@uams.edu. That's the APCD email box, and that's where you can inquire for information. So that, I believe, concludes my 45 slides. Does anybody have any questions? Oh, yay, thank you.
So you said it takes 6 to 12 weeks to fulfill a request to give access to the system or to give a data set from that?
Great question. Right now the model will be to deliver a data set. If it's small, we're working on a model that might look like a subscription where you would have access to a copy of the data set depending on the use and the price point. But you're not going to, right now, the external user will not be able to mine the data set, the database itself this year.
So why does it take 6 to 12 weeks to get?
Because of this process.
Well,
It's paperwork.
it's a lengthy process.
Once we get down here to this blue box that says ACI pulls the data, it's not going to take 16 weeks. I apologize for that. This lady here had a question. Yes.
Is ACI itself funded?
Is ACI self-funded? That's a great question too. ACI predominantly operates off of grants and contracts, about 60 to 70%, but we have some foundation money. We call it our core, that is provided annually by key sponsors, including the Health Department, Blue Cross Blue Shield, Delta Dental, Arkansas Children's Hospital, and UAMS.
So will it be a fee? I mean, will you pay a fee to access this?
There will be a fee, yes.
And what's the fee structure?
That is still being developed.
Okay, and on the HDI,
Mhm.
you showed that you had to get approval from all of the individuals.
Mhm.
Do you do that for the investigator, or does the investigator have to approach each of those entities and get
Usually we
approval?
do it. Only once have I ever participated in a project where they did it. And I don't remember why, but usually we do. We have the relationship, so we would initiate that.
So just for giggles, for somebody that doesn't live in this world, give me an example of what somebody might ask.
For the HDI?
No, for this.
Okay. Well, we get a lot of requests for data sets for dissertations. But subject-wise, there is a lot of interest in, let me think, health disparity. There's a lot of interest in assessing the impact on the medical infrastructure for dually eligibles. There's a lot of interest in Medicaid, Medicare overlap. There's a lot of interest in hospital utilization for emergency department visits. Oh, gosh. Hang tight. The APCD data is used in the private option evaluation to assess the effectiveness of the private option, individuals with new coverage, how they're accessing the medical system. And ultimately, we have built a prototype, I can't show you here, but of a price tool where we have selected several different procedures. We started with dental procedures, and when we have all of our stakeholder approval, the consumer will be able to select a dental procedure like an x-ray or a filling and get a price range and then information on how to verify the price that for them. There will be a consumer tool.
So for example, could you look at patients with a diabetes diagnosis in Chico County versus
Yes, sir.
Washington County,
Yes.
and who's on metformin
Mhm.
or TZDs?
We don't have, it's health insurance claims, so we don't have clinical data from a chart,
Right.
but we absolutely can do that. In fact, we have
But you
done,
got pharmacy.
yes, sir.
And you'd have diagnosis. So.
We did when EpiPen was in the news, we used our pharmacy data that we had at the time. We have a little more now, but to do our own analysis. It's not published yet. It's been used with the legislature, and it supported what the other states were seeing with EpiPen prices. We did a report with Medicare data that will expand to the rest of the database since we now have the private carrier data. That did just what you said. It tracked chronic conditions by county, and we had to, select our criteria based on the number of events, et cetera. So
One more, just.
yeah,
Didn't totally changing the subject.
yeah.
Did ACI work on the pseudoephedrine law?
I don't know. Not directly with data. Our policy team may have supported it, but they didn't come to the database. Yes, ma'am.
This is a data governance question.
Yep.
In light of the many different data sources that gets integrated into the data warehouse, who owns the data?
For the APCD, technically the insurance department owns the data. For the HDI, the data providers own the data. My microphone changed.
So what do you expect in terms of or following a particular individual, even though you do not have a PHI information for those patients or people, what would be the longitudinal follow-up duration that you expect? People switch from insurance to insurance, or if somebody say wants to do a study, let's say whether the patients were put on biologic agent for rheumatoid arthritis, did they get appropriate non-biologic treatment prior to the institution of biologic therapy? Would something like that be feasible in this kind of database?
It would be feasible to the extent that you can track it within a carrier and that you're comfortable with the limitations of the unique ID tracking across carriers. So you'll have the diagnosis, you'll have the procedure, you'll have the associated pharmaceutical treatment and the dates and the dates and the locations.
Do you have some sense of the stability of the insurance coverage for a particular individual? Do they switch quite frequently?
Oh, I see your, I can't tell you I don't know. I don't know.
So the data starts from 2015 and you're catching up. So eventually when you're stabilized, what is the lag time, like quarterly or?
Great question. Our first, I hate when that happens. Our first data dump is what we call the historical data, and all the carriers provided their 2013 through 2015 claims. And that was supposed to have been received last year. We have a few carriers lagging. So on March 2017, in 2 months or about, we are going to get, we're going to start catching up. So by June of 2017, we should have from 13 to the first quarter of 17, hopefully. Yes.
So if an investigator is recruiting patients and HIPAA authorizes for fully identified health information, are we able to work with you to sling you the identifiers and match and get data out of the database? Or would that not work even with HIPAA authorization because you're outside of the covered entity?
We're outside of that. We've been asked that before and we haven't been able to make that work.
But you can in HDI.
Well, are you talking about HDI or APCD?
Well, let's start with HDI because the data could be easily linked there.
Yeah. Well, we can't do it in APCD because we don't have the identifiers, period. Or the personal identifiers. And with HDI, we have been approached about that before to provide data, and then we provide the identified data back. And we have not been able to do that legally. We have not been able to work that out.
Okay, thanks.
Mm-hmm.
Are there other questions? Okay, if not, let's again thank our speaker.
Thank you. I have cards if you want them, and you can always email me or look me up on the directory. Thank you. Oh, let me just take over your machine here.
Kenny, that was very helpful to me. Thank you.
I'm glad.
I'm glad I
See you
saw
soon.
that.
You asked a question early on. Did I answer?